Thank you and welcome. And it's wonderful to be here. This is my first time in Georgia. Very exciting to be here at your wonderful conference. I spent some time in the 80s in Russia doing teaching, so it was very interesting to hear how much you have progressed in the last 10 or 15 years, and I can see a lot of changes. So my focus today, presenting on behalf of my team at the University of Queensland, is on looking at participation for children with cerebral palsy, and we have just completed a new randomised controlled trial of participation-focused intervention. And I'd really like to acknowledge my co-authors, Dr. Leanne Saksuski, who leads this work, Sarah Reedman, who's our doctoral student who's just completed the trial, and also our colleagues in Western Australia, Catherine Elliott and Claire Willis, who've been undertaking collaborative work with us. So this is part of our new Australasian Cerebral Palsy Clinical Trials Network. This is a network of centres across Australia that is focusing on, and these are many of my colleagues involved in this network. It's a 5-year Centre of Excellence program across Australasia. And we have a vision. One of our visions in this network is to conduct multi-site randomised clinical trials to develop and test new interventions and rehabilitation methods. And this work is very much guided by a consumer network. The focus today in our themes is on the clinical trials component, and after this I'll be giving a separate session on early detection and early intervention. We are not only using this network to recruit and conduct randomised clinical trials, but all our work is involving consumers, in which we are doing consumer engagement and developing partnerships. And we're undertaking a series of development of new clinical practice guidelines. So participation is defined as involvement in a life situation, and there's been a lot of work in this area recently, particularly from Christine Imms and others, looking at life situations and how they may be complex routines in social contexts, but with the emphasis on meaningful goals. Attendance, being present in a desired manner, and involvement in both motivation and social connection. So these are important elements that we considered in developing this new intervention approach. Interventions are, of course, a way of acting or interceding to change and modify the outcome. But we have to consider, is this a facilitation component or is it actually enablement? So this is the Participate CP trial. It's a randomised, waitlist control trial that incorporated both motivational interviewing and behavioural change therapy to guide the intervention to increase physical activity through meaningful participation in children with cerebral palsy. And our full study protocol is published in BMJ Open. So just 2 quick cases to orientate you to the sort of children in our trial. This is Emma, who's 8 years old. She's functioning fairly highly, GMFCS1. She lives in just outside Brisbane, a metropolitan city that's similar size to Tbilisi. And she and her parents would like her to be more physically active. She has low confidence, a lot of anxiety with bike riding and physical activities in general, and she wants to do her bike riding more often. Sam, on the other hand, is probably like many little boys in Georgia. He wants to play rugby, which I believe is very popular here in Georgia. He likes video games, and he's also interested in history. So what are the approaches that we've adopted in enabling participation in physical activity? It's a complex health behaviour. Both at the individual level, we have to consider motivation, self-efficacy and self-belief. We have to consider the physical aspects, but the environment, context and societal aspects, as discussed yesterday in the ICF, are very important. Not only accessibility, environmental contexts, resources and programs, the family factors, and the societal attitudes and policies. So therapy programs have frequently been targeted at the individual. When we consider a participation-focused, we have to consider the societal perspective of function. So we have to consider all these different aspects that are involving a participation-focused therapy. So interventions for participation in physical activity are not just about strength and fitness training at the activity level of the ICF. They are directly wanting to make meaningful changes in participation. So we use this framework by working collaboratively with the child and family and the therapist. We do mutual goal setting. We assess the child and their family in the context, the environment in which they want to participate, look at their strengths and try to overcome any barriers to that participation in those goal-directed activities. We then develop and implement a goal-directed therapy that's very targeted and individualised to that child and evaluate the processes and outcomes. So the gold standard for a participation-focused therapy should be goal-directed, family-orientated, collaborative, strengths-based, ecologically valid, self-determined using self-determination theory, and individually defined. There's been many systematic reviews that have looked at the participation-focused area and have incorporated different patient groups, a broad age, 6 to 16, and looked at different approaches such as coaching, leisure context, skill-based training, and goal-directed training, and looking at different outcomes according to that participation. But in many of these trials, participation was mostly an assumed outcome. Often the interventions were focusing at the activity level, and an outcome of enhanced participation was assumed but not always achieved. So we have to think about participation both in its subjective and objective contexts. So let's unpack this participation-focused intervention. What's in the black box? Well, the very important ingredient is the individualised goal setting and the engagement with the family. So the intervention is multifaceted. It includes both home and community-based activities, so with the child and family directly in the home and in the community with which they want to participate. We use a goal-directed approach so that it is meaningful to the child. We use a motivational interviewing approach to help overcome any barriers and to contextualise it directly to the environment. And the therapist is very family-centred. So we have followed some of the work of Richard Ryan and others, looking at the basic psychological needs theory, which incorporates both autonomy, competence, and relatedness, which are key theoretical underpinnings of this research. And if we're thinking about the intrinsic motivation for goal pursuits, his work has shown that intrinsic motivation intrinsically motivated behaviours for positive behaviours are more relevant than a carrot or stick. So we think about this ourselves. In things that we really want to do, that we're intrinsically motivated to do, we're more likely to have an effect than we are an extrinsic motivation. So these are the main factors that we've considered in this approach. There's an increasing amount of literature on coaching approaches, which have been described. You can see a definition there of coaching approaches, similar information about being collaborative, building capacity, client-centred, self-determination, being characterised by positive language. And the key elements in solution-focused coaching are there described in the literature. And we have followed these approaches in the development of this program. So how do we do it? A participation-focused therapy with a behavioural emphasis. We establish the desired outcome with the child and family. We examine any behavioural barriers that might be evident both for the family and child or in the community, and we think about the facilitators to overcome in that particular context. Then we agree and set specific SMART goals, and I'm sure most of the clinicians in the audience understand what a SMART goal is. And then we devise strategies where we can match up and overcome any barriers that might be a problem to facilitating this participation-focused intervention. So here's an example. Oliver is an 8-year-old boy with cerebral palsy. He's fairly high functioning, GMFCS1, max 1. His desired outcome is to attend and participate in an extracurricular Australian Football League for about 60 minutes per week. His outcome will be measured in 8 weeks. So we go through a process of choosing and setting goals, measuring it using the COPM and the goal attainment scale. Decide who will participate in the scoring, Oliver and his mum together, who will play each part, and then set the goals and define objective and subjective ways that we want to look at the outcome. So Oliver scored the COPM together with his mum, Oliver and his mum taking the lead, and initially put his goal at 1 for performance, 7 for satisfaction, but very highly 10 for confidence. We used then this measure, a theoretical domains framework, for he and his mother to look at how the child might be regularly participating in physical activities or sports of their choice. So this is a useful tool in looking at the theoretical domains underlying his choice of goals. We also used a tool to look at examination of any barriers that Oliver might have, which he talked about a lack of knowledge, skills, his problems with beliefs about his capabilities, and his mother also completed this tool and showed that she had problems with knowledge, but not being optimistic about his ability to achieve the goal. So then we used a motivational interviewing framework to think about how we could overcome these barriers to his involvement. We find that you have to look at any doubts and resistance, express empathy by showing you understand where they're coming from, what their problems are. You need to develop, highlight the differences between the current abilities that he has and the targeted participation he wants to achieve, and facilitate the development of competence. So we use this motivational interviewing as a framework for our motivational interviewing part of the intervention. So what does this look like? For therapists, we would often have focused as a physiotherapist on his AFL skills, his football skills. But we also had to think about this motivational interviewing as to how to facilitate him to overcome any barriers that he might have, give him reassurance and look in the community as to how we were going to overcome any barriers, and then build his self-esteem through and contribute to success. So, after one motivational interviewing session with his family, his mother decided to enrol all the siblings into one AFL team. The club independently came up with ideas where Oliver could play at a lower age range and sought permission on his mother's behalf. The club also provided them with football boots for free to overcome any financial barriers. And at the next session, the mother already said, I realised I was the part of the barrier. I had thought it would be too hard, but once we did it, it wasn't at all difficult. Oliver was highly motivated, and by wearing the same football colours as his father, he felt positively motivated. He did lots of practice of targeted kicking practice, building his confidence and continuing to overcome his barriers. After the sessions, at the end of the 8 weeks, he scored his performance at 10, an improvement of 9 points, his satisfaction at 10, and he was obviously still very confident. So this randomised control trial has been just recently concluded, and it was the subject of an editorial by Jan William Gorter before we started, after the publication of our systematic review, where he highlighted what we were saying, that physical training alone to increase participation is not recommended as the standard of care. Interventions need to include a behavioural component to have the best potential to improve physical activity. So we were on the same page as Jan William. We totally responded to his comments. So in physical activity, it's very important to realise in measuring physical activity in children with cerebral palsy, they have reduced physical activity, but skill-based interventions from our systematic review alone do not equate to an improvement in participation in physical activities or the amount of physical activity. So just doing skill-based therapy is not enough. So habitual physical activity can be measured in many ways. We do it with triaxial accelerometers. We look at the amount of sedentary behaviour, low physical activity versus moderate to vigorous physical activity. And these are the Australian guidelines where we look at whether children around this age group are doing more than 60 minutes a day of moderate to vigorous physical activity would be the target behaviour. In our systematic review and in other work, we've shown that there is difficulty, some challenges in looking at this link in participation in physical activities and increasing these levels of moderate to vigorous physical activity, increasing higher levels of low physical activity and reducing sedentary time. One of the things I should highlight though is just measuring physical activity with accelerometers doesn't tell us the mode of activity. So what were they actually doing when they wore these actigraphs and physical activity monitors? Were they changing their mode of behaviour? So our aims were, in this intervention trial, to have a participation-focused intervention that was goal-directed, motivational and physiotherapy-directed. So we aim to increase their participation in physical activities by choosing higher levels of physical activity, overcoming behavioural barriers and improving their quality of life. It included both individually self-important, self-directed goals that were collaboratively set, and we had this waitlist design where children were either randomised to receive the Participate CP immediately, or after a period of waitlisting or usual care therapy, they then would receive the therapy. So this is a great way to ensure that all children who enter the trial will eventually receive the therapy. So the design, our primary outcome, was the Canadian Occupational Performance Measure to look at these participation-focused goals. Secondary outcome were looking at barriers to participation, child-reported quality of life, participation and environment measure, the PEMCY, and physical activity monitoring over 7 days. Who was involved? These children, 8 to 12 years, with their primary caregiver, who wanted to participate in physical activities and had sufficient cognition and communication to be involved in goal setting. This is the physiotherapist, Sarah Reedman, who has a lot of experience, and she undertook specific training in motivational interviewing. The key principles, as I've mentioned, were self-determined and behaviour-orientated approaches, family-centred and goal-directed, with a collaborative goal setting. And then this was set in the context of what the participation goal was, where in the environment they were multimodal and individually tailored. So it included a direct 1 hour per week goal setting session over the 8 weeks, home visits, either to the home or the community, goal scoring after the 8 weeks, and then ongoing participation to build that intrinsic motivation. And this included many different strategies from the toolbox that were set with the child and the family to problem solve continued participation in the future. So how do we do this? With clinical reasoning. We used motivational interviewing, self-confidence and self-efficacy to scaffold participation for success and promote a social connection for that child in the environment in which they wanted to participate. We looked at their knowledge, the services that were available. We've now developed an app with our Canadian colleagues to look at where services may be available for different participation-focused interventions. We then had to look at the community attitudes in where they wanted to undertake these activities, the equipment, any funding barriers. And we looked at the activity capacity. It might have required specific sport skill training for some aspects. It might have incorporated some motor learning approaches, and we used the co-op approach for looking at improving motor learning. We also looked at the child's balance, strength and endurance in the context of their goal. So we might have measured and influenced their overall competence, their speed, dexterity, other quantitative factors or their quality of movement, but really the emphasis is on measuring and improving participation. So this included both attendance, involvement, their enjoyment, their preferences and satisfaction, and their confidence. So this is the difference between an activity-focused intervention, which it might have been Jack learning to dribble his basketball, versus actually Jack playing in a team and being involved in a basketball game. We had 37 children randomised, 18 to the immediate participate group and 19 waitlisted. We had around 3 goals per participant, which included both formal activities and informal activities, which looked at both attendance and involvement, but predominantly attendance. And the intervention group, 87% of the intervention group, immediate intervention group, achieved greater than 2 points on the COPM, which is a clinically important change, after 8 weeks. The waitlist group set goals, which I imagine did have some influence on the outcomes, but they only increased 28%, by 28% achieving their goals. So here we see the data on COPM performance, and in blue the intervention group from baseline to 8 weeks at 6 weeks, 16 weeks retention. And we see that Participate CP is effective in improving perceived performance and satisfaction with individual physical activity participation goals. We also looked at barriers to behaviour change with our tool, and we see that Participate CP was effective at reducing parent-reported barriers and changes in physical activity behaviours for their child. We also did a motivational measure where we looked at, in the intervention group on the right, there were significant changes in interest and enjoyment, in fitness and social, and some improvements in competence and appearance, but these were not significantly different. So back to measuring physical activity, a different construct with triaxial accelerometers. In this, we did a 7-day record. We looked at GMFCS-specific cut points for measuring our level of physical activity. And we wanted to look at the level of increase in moderate to vigorous physical activity, and also reduction in sedentary time. We looked at both raw counts and physical and time components. Overall, we had a large number of episodes of wear, 68% of usable data, which is for 7 days quite a lot. We had some difficulties with some compliance. And an important thing to consider is the number of children, proportion of children who met physical activity guidelines at baseline. So we had 11 children, 37%, who already were highly functioning in their physical activity at baseline. So there were no significant differences between the groups in the randomised control overall, in the treatment versus control, for increases in moderate to vigorous physical activity. However, when we looked at both groups pre-post the intervention, 9 out of 20 of the participants had increased their moderate to vigorous physical activity immediately post-intervention. And we found that the responders were the children that had low physical activity in the beginning. So Participate CP might increase habitual physical activity for children who were low active at baseline. So if you already had high levels of physical activity, that was not going to change, but it did change for the children with low activity. So these differential effects are interesting, and we'll consider this in further trials, in that potentially it's going to have a differential effect according to your level of activity in the beginning before these trials. But I think the other thing to be important about physical activity in relation to participation, it only talks about activity. It does not talk about the mode or the actual participation, which is why we selected the COPM for the participation-focused goals as our primary outcome. So in conclusion, this is a multimodal, holistic, tailored behaviour change model of therapy. It was effective in improving participation in physical activity, and they met their participation goals and were satisfied. We also showed that goal performance facilitated this ongoing self-efficacy, and that children retained this improvement beyond the intervention component and overcame their perceived barriers, and we had better enablers. So we feel that this is a paradigm shift. This is a specifically targeted participation-focused intervention. And I know other groups have done small pilot trials in this area, but this is the first adequately powered randomised controlled trial that's participation-focused intervention. And that is the primary goal. But it is you gain what you trained. And Anki Eliasson would always say this, that if what you target very specifically is participation-focused directly in that area, you will have success. If you're focusing on activity, and which is more related to strength or fitness, you can't assume the participation will increase. So children who in the physical activity were more active than we previously estimated. So Australian children, GMFCS 1 to 3, are already quite physically active. And there was some clinically meaningful changes in participation in physical activity for those children who had low levels of activity. So we've updated our systematic review, and I know this is a very busy slide, but it's telling you that basically with the addition of our trial that there's good evidence in a small number of studies, but in a small number of participants for improving participation-focused goals. There also is some improvements in physical activity with more modest effect sizes overall. So in updating the systematic review, we've shown that this is what's important in a participation-focused intervention is to not only to think about the focus of the intervention, the environment and personal factors, and that the behaviour modification characteristics of the intervention are a very important thing. So back to what Jan William Gorter said to us before we started, that these need to be considered behaviour change in the participation-focused intervention. So this is strong pilot data for us now to undertake a larger randomised controlled trial. We use GMFCS-specific cut points in our physical activity, and we also look at the mode of activity. What sort of activity are they undertaking, as well as the level, the patterns of activity. And we want to now expand this to a group of children who are GMFCS 4 and 5. So we're now doing a randomised controlled trial across 4 states of Australia involving our Canadian colleagues and 4 states of Australia. We're also undertaking a project that's specifically targeted to children making friends and optimising their social competence. So a slightly different area, but this is targeting the peers program in another randomised controlled trial. We're also informing our research centre, the Australian Cerebral Palsy Clinical Trials Network, with consumer involvement. This is a consumer, Anne McKenzie, who does training in Western Australia for the whole state on consumer engagement, both training consumers to be involved in research actively and collaboratively, but also for clinicians incorporating consumers in their research. So what are the clinical implications of this study? Participation interventions ideally need to be multimodal with a participation focus. They not only need to be family-centred and goal-directed, with a goal-directed orientated outcome, physical activity but can be a health behaviour, but you need to consider those aspects of fun, freedom, friendship and fulfilment. Emma, who I mentioned in the beginning, learnt to do got a lot more competence for her COPM goals before and after the intervention for her bike riding, and she felt a lot more confident with riding with other children in her neighbourhood. Sam, who wanted to learn about rugby, had fairly low levels of COPM performance in the beginning for both performance and satisfaction about joining a rugby team. Initially, Sarah did some sessions where she looked at developing some of the prerequisite skills. And this is a session at home. But next, she then employed some strategies from a modified rugby program that she found on the internet. And she used this information to think, how can I extend his skills? And so she thought about other ways that she could incorporate this involving also the family. We can see that the dog's not very organised and he's not very focused. He's not participating. So his performance and his final outcome, he went to the big stadium in Brisbane where they play the international rugby games, and he was involved as a ball boy and involved in a mini rugby game. So that was his final result of his participation focus program. So we have been now doing this with multiple different participation focused outcomes with children with cerebral palsy. They have a cerebral palsy football program for children and multiple GMFCS 1 to 3 at all different ages. And those children are smiling from the moment they arrive to the time that they have to leave. We have this little boy is GMFCS 4. His parents were very keen for him to get involved in water sports because he lives on the Gold Coast. His physiotherapist devised where he could do stand-up paddleboarding with her strapped to the physio, and he could learn to use a stand-up paddleboard, which was quite remarkable. This little boy also surfs. He's GMFCS 4, and he goes with someone and he goes surfing. He also goes skiing. He has the opportunity to go skiing with his family. So I think you can see for a young man who's GMFCS 4, he's really actively participating in society. So I'd like to thank you very much for the opportunity to talk about what we feel is a real paradigm shift in our work on participation-focused interventions. Thank you.